Hello, good morning, and welcome. It is 7:13 in the morning. I was supposed to have a 7 o'clock patient this morning, and they did not show. So I am going to do this lecture, and so my voice has not yet caught up, and so I probably this it does sound very smooth. I kind of sound like a night like Barry White, basically. Those of you uh, that are not of my age bracket may not know who Barry White is, um, but he's awesome. Um, it's good stuff. I am a very lucky man, and I'm a very lucky man because I get to be a dad to these two beautiful girls. Um, and it is their birthdays this week. In fact, I'm recording this on Friday, September 12th. And today is Avery's birthday. Avery is the brunette. Um, and Monday, the 15th, is Cora's birthday. Cora's blonde, one that looks like me. You can do the math. Um, there is no greater privilege that I will have than to be the dad to these two. Um, obviously Cora turns 9. I've had hers from the beginning, and being her dad is has been my greatest honor and greatest privilege to watch her grow and become the little person that she is today. And then Avery, uh, entered into my life a couple years ago, and um, even even with that, and not to get too deep into it, but she needed a father figure to be there for her. Guess she didn't need it. She's an awesome kid, but boy, it'd be nice. And so to be to get to be that person for both of them, to get to show Avery what you know a dad's love is all about is pretty cool. And so Avery turns 12 today, and Cora will turn 9 on Monday. And I'm so happy that they have each other, and their sisterly bond is just growing, and it's so cool to watch them, and I get to be a witness to it. So from that standpoint, it's pretty cool. This life's pretty cool, and it's good. Life's good. All right, let's talk about screening tools this week. Um, so screening tools serve as a mechanism to direct patients towards the most appropriate form of treatment. However, patients should always have the autonomy to make decisions regarding their care. Now, this is sometimes difficult to think about. That, I think, as I said before, um, I had a patient who came into my office and they had just downed all like half a fifth of bourbon. Brought the bottle in with them. I'm like, thanks, I don't need that. But um, and so like they were drunk. I mean, they were drunk, and I was like, do we need treatment like now. They're like, I don't want treatment. I'm like, well, we need this. This is not the level of care that you need or that is working. Like, well, I like you. And I'm like, I know I'm likable, um, but we need a higher level of care. So even as I do screening with them, we'll talk about the audit, um, alcohol use disorder identification test. And the audit, I mean, they were like 38 out of 40. Like, bruh, you need to go to treatment. And they didn't want to. They want to go do something else. So that was their autonomy to make those decisions, even if we think that's probably not best. We've had some patients that, like, or when I was working at Journey, like, we had some patients who desperately needed to go inpatient, but they would not. And so we just, all right, we're going to do IOP. And they were agreeable to that. We had some that desperately needed inpatient, and they just said, you know what, I just want to do outpatient and a group. And that's what they did. That was their plan. So, so again, as we talk about these screening tools, it's a way to direct patients to what would be the most appropriate form of care. And at the same time, patients may not choose that. And that's okay. It may frustrate us as clinicians, but they have the right to do that, right? Okay. Because everybody's situation is going to be different. We don't know where someone's at. And so it's up to them to figure all that stuff out. Okay. During your clinical interview, for as much as you are screening the client for the content of the session, you are also paying attention to speech, mannerisms, word choice, and behaviors. Noticing these can assist in contextualizing their issues and aid in developing your conceptualization of their process and experience. Now, we're going to talk a little more stuff that like gets into the behavioral health realm, and just behind the curtain, that's internal discussions that we're having is how much, yes, we want to focus on addiction, but quite honestly, most of what you're going to see in addiction is co-occurring disorders, and they got something else too. So it's important to know. So as we kind of go through this is the densest that this class gets. Okay. What we do here is heavy, and it's a lot of information. And so much so, this is like the only one where I put the slides on the canvas so that you can go back and look and read and check it all out. Okay. Because this is a lot of information. Even if you're taking notes, this is a lot of information to digest. So I put it all out there so that you can see it, because we're going to talk about like states of presentation. All right, that'll make sense as we go through. Okay. So one of the things that you're going to be looking at is a mental status exam. No matter where you practice, if you practice as a therapist, or even if you do, just like case management or some of your peer supports, you can do a little like mental status exam or a mini mental status exam, or just kind of know what they are. You may not do a formal one, but you can go, oh, I know what that is. Okay. So we're going to look at a couple things. We're going to look at the thought process. So how are they processing information? Okay. Because if they have some kind of abnormality in that space, it really has an impact on how they process information. If they are struggling with like delusions and, you're trying to help them see some stuff, they may not be able to process it in that way. Thought content. So what are their thoughts consisting of? So if they're, again, focused on those delusions or those persecutory beliefs, everybody's out to get me. Even you saying like, hey, I think you need to go to treatment, they may be thinking, oh, you're just, you're working with them to try to like keep me from blah, blah, blah. Like, no, I just think you need to go to treatment, but that is not going to click for them. Okay. And then disturbances in perception. How is one organizing their thoughts? How are things being framed in their brain? Schizoaffective and schizophrenia, versus substance-induced mood disorder. So like if somebody is struggling with methamphetamine addiction, some of their symptoms can mimic schizophrenia or schizoaffective disorder. Okay. So recognizing that, knowing their substance that they're using, knowing the things that they're if they come in and they have never shown any signs of schizoaffective or schizophrenia, and yet they show up to your session and their mind is racing and they can't sit still and they're pacing around and they're hyperverbal and they've got all these different conditions, you could see, oh, wait a minute. This is not what Jane normally does. There may be something deeper there. Okay. Let's talk about delusions for a second. So these are all different delusions that patients can have that, again, can play a role in how we're describing what they're struggling with. Okay. So grandiose delusion, having an overinflated self-confidence or sense of self. Okay. I'm much bigger. I'm much better. I'm going to be the greatest. I'm going to be rich. I'm going to be blah, 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 blah. We all had a little bit of that with the Powerball a couple weeks ago. We all thought, oh, we're going to get rich. And we didn't. Sorry. I'm not sorry. It's not my fault. I don't run the lottery. Persecutory delusions. So these are unwarranted fears, beliefs, or hallucinations that other people are out to cause harm. Okay. Somatic delusions. And I'm starting to see this a little more in functional mental disorders. I'm seeing it FMD. People are will somaticize problems that they have to certain parts of their body. Okay. So there's this belief that something is physically wrong with the individual. It may involve a medical condition or an illness or a perceived deformity. I'm starting to see more where like someone is stressed out and suddenly like their arms don't work, or suddenly like they can't write because their right hand is cursed, and so therefore they're afraid that like signing their name or writing anything down will lead to that being cursed. So like that's a somatic sort of, there's something wrong with my body such that I cannot function. Bizarre delusions. These are just delusions that are patently absurd. Little green men, etc. Nihilistic delusions. I do see some nihilism. If you don't know what nihilism is, it is the belief that like nothing matters. Like, why are we even here? Because we're all going to die, so it doesn't really matter anyway. So everything is meaningless. Nothing has meaning because it's all going to die and end. And so why am I even here? But there can be a delusion there, which is that like oneself, a part of like one's body or the real world does not exist or has been destroyed. And they're all the way in it. Like we're in a simulation. And so none of this matters. Okay. I see a lot of religious delusions, especially in schizophrenic patients, but also you'll see it with people who struggle with stimulant use disorder. Specifically methamphetamines, sometimes cocaine, but more often than not, methamphetamine. A delusion involving religious themes or subject matter, also common in schizophrenic patients. See this a lot. I mean, there's this idea that one is Jesus, one is God, Jesus-like. It may not be Jesus particularly, but that they are, and it differs from grandiose because this involves them seeing themselves as a specific or general deity, to where they are like God, they think like God, they have greater powers than everybody, kind of thing, or they are a martyr for a religious cause. Oftentimes it can be Christianity, but there can be other things that they feel as though they are a martyr for. I'm being persecuted in this life for greater purpose or whatever. I'm suffering for greater purpose. Can also be part of it. And then ideas of reference, a phenomenon that an individual experiencing innocuous events or mere coincidences and believing that they have a strong personal significance. It is the notion that everything one perceives in the world relates to one's own destiny. So they will believe that something small, like you picking up a pen. I have a lot of pen-related analogies. You picking up a pen is a meaning to something, or something just generally small and simple has much greater purpose and bigger purpose. Like a Canada goose crossed the street, and that is telling me that I need to wait a little longer because I had to wait for it to cross the street. Okay, it's an idea of reference. Hallucinations. These are just types of hallucinations that someone may see. Again, you're going to see this more with schizophrenia, with methamphetamine use disorder, because it activates the same parts of the brain that are activated when somebody is struggling with schizophrenia. So auditory hallucinations, perceiving sounds without auditory stimulus, for example, hearing voices. Olfactory, smelling something when there is nothing in the environment producing the odor being experienced. Gustatory, perception of taste without a stimulus. Tasting blood is a common one. Tactile, the sensation of physical contact with an object that isn't there. And then also I don't know why it's not on here, but it is very important. Visual. Early morning, my allergies just kind of don't like me. And that's fine. They are allowed to do that. Whoa, don't want to bold that. The perception of stimuli that are not present. Okay. I don't necessarily like that, but we're gonna go with it. Let's just simplify. Seeing things that are not really there. Let's simplify. Be simple. Occam's razor. Okay. Perception and thought process. All right. Derealization. This one is very, very, very common, especially when we get into the hallucinogens and the psychedelics. Okay. Derealization, a feeling that one's surrounding are not real, especially as a symptom of mental disturbance. None of this is real. None of this exists. I don't exist. You don't exist. We may talk about depersonalization in a couple slides. I don't remember, but it's the same kind of concept that the feelings that one's surrounding are not real. Okay. Tangential, probably that one is easy to wrap your mind around. They just kind of go off on a tangent, and there is no general like it is connected. Because they'll say like you talk about apples and I remember when I went apple, but like you're talking about clinical stuff and like haven't really been eating. The last thing I had was an apple. Well, I went to an apple orchard once and blah 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 blah. Like that's a tangent, right? One tends to digress readily from one topic under discussion to another. Okay, because there is an association. Circumstantial, unnecessary details and irrelevant remarks cause a delay in getting to the point. I have a patient like this who like just gives me every unnecessary detail. I'm like, I don't need all, but they just kind of go, and it's important to them. It doesn't get in the way of our stuff clinically, but it is something that it does get in the way of like getting, and so sometimes I have to redirect and I have to like, look, Jane, we need to get back to where, okay, I know, appreciate the context. And to them, it's very important. It's their anxiety. But and I will indulge from time to time, but they will go into full unnecessary detail because it's important to them. Okay. Incoherent, not linear with a coherent theme and difficult to follow. These are really difficult because you want to think that they're all what they're trying, like you're trying to follow what they're trying to say. But the last time that I was a chair, I went into the supermarket and I had a couple of bananas that were going to be put into a jar. And then when I stopped at the flower shop, there were a few trucks that were behind the glass. And when I went to go pick one up, I fell into a secondary dimension and grandma went dancing. The hillside wears the dress. I can't find the sky. So concrete is thinking that objects or ideas are specific items rather than as an abstract recitation, more of a general concept. Okay, for example, perceiving a chair and a table as individual useful items and not as member of a general class, furniture. Like I can't see, like this has a specific thing and that has a specific thing, and they cannot combine. They cannot be collectively furniture. That is a chair, that is a table. They do not match. They do not match. They do not connect. And so again, when you are, I had a patient sort of like this recently, who everything was very black and white. Everything was very literal. They were not able to really kind of see. And as you guys know in class, I like to use analogies a lot, and that does not work. that way did not work. Any analogy that I would use was just not, they were not able to get there. So, I would say one of my favorite expressions that I like to use is you don't have to set yourself on fire to keep everybody else warm. And they went into like this whole thing of, well, where would I get the matches and why would I put myself on fire? And that doesn't make any sense because I don't know that I would burn that well if I didn't have concrete or if I didn't have gasoline. And then it turned into, but why can't everybody, like, why do they not have coats? It's cold. If it's cold, why don't they just wear coats? And it's like, that's not the point. Okay. So everything was very concrete for them. Okay. Here's a few others. So, blocked is a sudden cessation of speech in the middle of stream of talk, right? No clear reason, but they just kind of stop. I do have a patient that does this whenever we start to talk about, like whenever we start to connect, because a lot of my therapy is the past is in the present. And so things from childhood come to the surface in adulthood, and that's what causes our distress. When she starts to access things from childhood, she'll just stop, like whenever something pops up, and it's just like, whoop, shut down, and she'll sit and stare for a long time. Okay. Loose, it's connected somewhat to some of the stuff we talked about before, but minimal connections between thoughts. The thinking process is nearly, but not completely random. I put an example there to show you, but it's just these like a general. You got a general theme, but it's just not. Again, it's just a loose kind of connection. Like it's kinda, but not really. And then there's flight of ideas, in which speech are fragmented. This is, an idea is stimulated by a previous idea or an external event, but they're kind of weak. So a flight of ideas would be like, you know what, it's my birthday and I think we need to go gambling and let's go to, we'll go to the casino and then the casino can give us money and the money would then let us go to Dayton, Kentucky, and then we'll go to Dayton, Ohio, and then we'll just make a triangle and we will take, I love triangles and bakeries. There's like croissants and different scones. I do love scone, a good scone that comes from England. England is, there's connect, but it's just like this flight, like it's just whatever is coming is what's going to come. Okay. Yeah. Thought content, again, delusions we've talked about. All right. Actually had a patient like this not too long ago that had a firmly held and false belief that is not based in reality, and they were not able to consider that maybe that's not true because they were convinced that it was true. And so even when I sort of said, it's not that I don't believe you. So when somebody goes into the delusions, when I don't really want to challenge it, I'm like, okay, so what evidence do we have to suggest that that is true? Well, I don't have any, and it's unbelievable. Okay, so it's unbelievable. So what is the importance of this thing being true? What would change given that this is true? Blah blah blah. Right. So it was. I don't want to get into specifics because HIPAA stuff, but like, there were just some things that were difficult to believe because they couldn't possibly be real, but that's beside the point. And so we just kind of roll with it, right? I don't want to necessarily challenge it because that's going to ruin the rapport. Obviously I'm not going to say it's true because that's not for me to say. But what I will do is say, okay, given that that is what exists for you, how do we keep ourselves safe? What do we do with that information? Just kind of rolling with it. Sometimes there can be obsessive thoughts. Okay. So an idea that is intrusive and ego dystonic. It should not be confused with ruminations, which are ego syntonic or delusions. Okay. So by definition, they will stay based in reality, but know that the obsession that they have makes no sense. Kind of like mine with Taylor Swift. There's also an overvalued idea, which is a false belief not shared by members of the culture that is not fixed. So, for instance, it is held more firmly than one would expect, but they can still stay in reality. Okay, so culturally, we know that we have no kings, basically. But someone can overvalue the idea of themselves being a king of America. Okay, so it's held to, but like I'm still based in reality, but I'm gonna have this idea that like I'm overvaluing this thought, or I'm putting too much weight into this thing that is going to make meaning in my life, right? So I'm gonna become the CEO of a company. Um, and then that will bring me value. Okay. Paranoid ideation, you're probably familiar with that. Suspiciousness about others' motives and ideas. Okay. Um, and then phobia, which is a specific fear that has no base in reality, like spiders. Some of you are probably scared of spiders. You're fine. Spider Bros are there to help you manage the bugs in your home. Spiders are wonderful. Do not kill spiders, unless it's like a tarantula. If you got it, not a tarantula, black widow. And if you got a lot of black widows, then move. But a phobia is just a specific fear that results in the avoidance of the situation or the object, despite the realization that this is irrational. Okay, cool. Couple more. Mood and affect. So, euthymic, just a normal, non-depressed, reasonably positive mood. Like, yep, things are good. Went to work, had lunch, things are great, right? Euphoric, just, oh my God, I'm over the moon. Like, oh my God, I just met this new guy and he's just amazing and I'm so happy and he's, blah, 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 blah. We're through the roof and everything feels really great. Okay, which is different than euthymia, which is just a general, like, I'm fine. Affect. Affect means emotional expression. Okay. So, how are people facing, expressing, having our emotions? And I just got a text. I'm getting the new iPhone. Isn't that an exciting day? Um, the 17 Pro Max, because I am indulgent, and and it's a good day. And I'm switching to Verizon because I'm on AT&T, and I've been loyal to AT&T, but AT&T is kind of letting me down. This message paid for you by, or paid for by Horizon. God, if you're going to tell a joke, tell the joke. This message was paid for by Verizon. There, good. Um, so an affect is emotional expression. How available are my emotions, etc. Okay, so if I have a full affect, that means I'm experiencing highs, I'm experiencing lows, I'm experiencing goods, I'm experiencing bads. Like all of those things are coming out. I'm scared, I'm afraid, I'm happy. I'm like all of the emotions are readily present. Okay, constricted means like I'm only experiencing like a couple of emotions. I'm only able to be in happy or sad or maybe like upset. But like fear, joy, like all of these other things, like I've got a range. My amplitude for what I have is there, but I just am only able to experience a certain amount of emotions. Trauma patients or trauma survivors are like this. I'm only able to do a few range of emotions because of where I'm at. Okay. Um, Flat. So someone with a flat affect will present like this. Just no real emotional range. Very monotone. Sometimes they can be a little bit expressive, but or the fluctuation, the tone in their fluctuation will, but just very flat. Very, there is no. You could tell them that they want a $500 scratch off. That's cool. You could tell them that their dog died. That's cool. You could tell them that you know, they got a promotion at work. That's cool. Just very flat, right? You could tell them a joke, and they would sit there like this, kind of like many of you probably do during these lectures. Just okay, right? Just completely absent of expression. Okay, inappropriate. So like sometimes when I had a coworker once that anytime something horrible happened, they would laugh. And they said that started when they went into a home. They work with kids, and they went into a home, a foster home, or They went in. They worked for the a foster care agency, and they went into a home to get a kid. The state called and said, "Hey, come get this kid." And when they got there, the police and stuff were there. And the reason they had to get the kid is because the father had committed suicide in the home. And the kid was there when it happened. They were like 5. And like the kid walked in, saw dad dead, walked back out and said to my coworker, "My dad's dead." Just very like, this is what this is, because at 5 years old, that's what you say. And so she said that when that happened, the tragedy of everything overwhelmed her, and she just started laughing uncontrollably. And like, that's horrible, you know? But also that's that's what these lectures are good for, right? If you're ever wondering like, oh my God, Jordan goes on forever, these lectures are awful, probably. But like, that's the non-book stuff that you're going to get, right? Is those kinds of stories, because that's the reality of the field, right? The field is very is God. But anyway, so anytime something horrible would happen, she just starts laughing, and we all kind of knew about it. Like if we got bad news, she just starts laughing because that's what her stuff is. And then labile, which is unpredictable shifts in emotional state. So sometimes they're up, sometimes they're down, and it can happen like almost a shift. But I just think about all the times that we were together. Like it's just this very up and down sort of shift that can happen. Okay. This is the last section, then we'll get into some other stuff. And I'm going to go through these kind of quickly. So behaviors: dystonia is movement disorders where sustained or repetitive muscle contractions. Okay. So they'll kind of move. It's very dystonic. Okay. Tardive dyskinesia is a result. It's there are antipsychotics that patients will be on, and it will cause like stiffening. Okay. All right. Okay. That's tardive dyskinesia. Anhedonia is just the inability to experience pleasure. You'll see this a lot in patients that are in their recovery. Their first few months they'll have some anhedonia because the things that used to bring them pleasure don't anymore. And you also see that in major depression. Akathisia or akathisia is a state of agitation, distress, or restlessness. That's a side effect of an antipsychotic. Okay. Cooperative, I mean, that's your normal one. Just, I'm able to help you. I'm able to be here, be in that space with you. Okay. Impulsivity, you know what that is. Over sedated, drowsy, or lethargic. Assaultive, meaning, I'm just going to be, right? Assaultive, you know what that is. Hyperactive, again, you know what that is. And withdrawn, you know what that is. Okay. Those are easy to sort of see and spot. Cool. That was dense. But noticing these behaviors are important to remain effective with diagnosing and treating substance use disorder. Okay. And again, some of this is the different, like noticing these differences really help in understanding whether somebody is struggling with SUD or there's a mental illness going on. Okay. So we're going to look at 3 screening tools. Okay. We're going to look at them pretty briefly. Screening, brief intervention, and referral to treatment, otherwise known as ESPERT. It's also what Ernie said it's also what was said to Ernie when he okay, never mind. It's I can't do jokes at 7:45. I was going to make an ESPERT joke about Sesame Street, but it's over now, and we're just going to move on. So American Society of Addiction Medicine, or ASAM, and then the matrix model. Okay, so the ESPERT. So as you have probably noticed, so many things in our field are acronyms, and so the ESPERT is no different. So screening is a healthcare professional will administer a validated screening tool to identify the presence or severity of risky substance use behaviors. All of you can do an ESPERT. Okay, this is mostly targeted towards like primary care physicians, but all of you can do an ESPERT. All right. Case manager, peer support, you can all do an ESPERT. Okay. That includes an alcohol use disorder identification test or an audit, a drug abuse screening test, a 10 or 28 item, or a cage, which stands for all of those. Have you felt like you need to cut down on your drinking or substance use? Have people annoyed you by criticizing your drinking or substance use? Have you felt guilty about your drinking or substance use? And have you ever needed a drink first thing in the morning, otherwise known as eye opener, or to use a substance? Okay. And so this is just kind of like, you can use any, you can use all, you can use some, right? But these are just screening things to say, hey, maybe there's a problem here. Okay. This is the audit. Okay. A couple of things with this is you have to be very particular about some of these like numbers, right? The key is defining what a drink actually means. So for someone that wants to drink, we'll just say your standard lager, right? Bud Light. Okay. One drink equals 12 ounce of beer. But in most of your standard beers are 3.5 ABV, or alcohol by volume. Okay, 3.5%. And so if somebody is drinking like microbrew, that can have anywhere between like 6 to 12 alcohol by volume. Okay. So you could have someone that just is drinking an IPA and they drink a 6-pack a night, but that's going to look very different than somebody that just drinks, your standard lagers. There is a Kentucky Bourbon Barrel Ale that's really expensive, but it's like 12.5 ABV. And so if somebody's drinking a 6-pack of those per night, that looks very different than somebody that's just drinking lager. So it's important to get the type of alcohol someone's drinking, okay? Because that's going to have an impact on their functioning. So clarify that, because that's important. But then you kind of go through, and the key is that you don't put words in their mouth, because sometimes we have a tendency to do that because we get uncomfortable with space, and patients may have trouble answering. And we're like, okay, get this answer because I just want to move on to the next thing. Don't put words in their mouth, because they need to be the one to kind of acknowledge what's going on. Okay. So as you kind of go through this, it's just asking them very neutrally. If you're the one asking, it's oftentimes better for them to circle or fill it out themselves, but sometimes you're just in the space with them, and it's a good way. It's also useful for you to do it with them so that you can ask more questions. Okay. Because that's very important. So we want to ask it very neutrally. Okay. Okay. Now, don't worry about these numbers down here. What you're looking for here is, this is just saying, is there the likelihood that we have a problem? Okay. This is not what you're going to use to diagnose. We use those 11 that we talked about earlier. These are just used to screen to say, do we have a problem? Okay. Cool. Here's a DAST. You have the DAST 10, the DAST 28. What they found is that the DAST 10 was kind of sufficient to kind of cover everything. But if you want to get even more particular and screeny, then you can do the 28. Both are useful. Okay. We're just looking at 12 months, by the way. The same thing over here. I don't know if it says 12 months, but in the last year. Yeah, several things in the last year. So we're just looking at the last 12 months. Okay. That's important. So here's the BERT, or the BI, brief intervention. So depending on the screening results, healthcare professional facilitates a conversation. Okay. We're going to use a lot of motivational interviewing. And so if you don't know that, we'll go over them very quickly. So there are 6 stages, really 5 stages, but can be 6. First one is pre-contemplation, which is, I don't have a problem and I don't know what you guys are talking about. When they're in this space, you're not really going to convince them, because they're convinced that there's nothing wrong. Okay. No problems. Don't know why people are on my case about it. Leave me alone. Okay, cool. You're allowed to be in that space. So what we're trying to do here is just raise awareness that there might be a problem. Contemplation. Okay, maybe there's a problem, but I don't really want to make a change. I can recognize that something's probably not great, but I don't know. I don't really want to do anything about it. All right, cool. So now we're looking at trying to resolve that ambivalence. Like, you say that you don't really want to make a change, but you say the change could be helpful. Where are you at on that? Determination. Okay, something's problem, but I don't know what to do. I'm gathering resources. Okay. So we're looking at what would be appropriate for someone to help change. Action, which is I've got a plan and I got some things that are working. So I'm just going to try them out. I've got a few things that I'm going to be trying and we'll see if it works. And then maintenance, I found the thing that works. This is helpful and I'm just going to keep doing these things. Okay. Now, not everybody's going to have a reoccurrence, but if that's the case, now we have to figure out what to do now that some of these things have popped up again. Okay. And again, people can go from people can get to action and I've got some things that are working and then something doesn't work and they're back here like, why do I even do this? This is so stupid. Right. So we can all kind of go back and forth in any of this. Okay. So that's motivational interviewing. We're going to listen for change talk. So spaces where I don't need to quit. Right. So there's no area where you may want to quit ever. Well, okay. So, okay, good. That's change talk, right? Where they're starting to see the options that something could change. Again, we're going to use those ORs: open-ended questions, affirmations, reflections, and summaries. Okay. So the goals of brief intervention is just education. Okay. Sometimes it's just giving them the information, increasing the awareness of the consequences of substance use, motivating them towards change. Okay. And then assisting them in making those choices to reduce the risk. So you can do this in a few ways, right? We're going to just raise a subject. Hey, I just kind of noticed a few things on this screener and I just wanted to kind of talk to you about that. Is that okay? Providing those feedback look, I'm here for you. I want to help you. Obviously, I'm a healthcare professional. I want to make sure that you're healthy. That's all that this is. Enhancing those motivations. So determining their readiness. Okay, I can hear that you may not be ready to change. Is there ever a scenario where you might be? You say that thing, you say that you don't want to quit yet. You're kind of seeing some of these things with your blood work or with, some of the consequences. Your family's kind of saying some stuff can we talk about that discrepancy a little bit? And then also going through pros and cons. It's obvious to you why it's necessary to change, but it may not be to them. And then just kind of negotiate. What's our goal, right? I think, we've talked about inpatient treatment. Maybe you're not there yet. What are you willing to commit to today? Is there anything you're willing to commit to today and be in that space? Okay. We don't want to give a ton of advice. Those of you that are peer supports can help a little bit more there. But remember, this is their journey. And so we are here to help guide them and help them move through that space. Okay. Because if you give too much advice, it can actually push them away. Then finally, referral to treatment. We're going to go through these levels of care later in the semester, but the levels of care, we got 6 of them. Outpatient, which is just standard, you go to see St. Elizabeth Physicians, right? Or you go to Journey Recovery Center. That's outpatient. You've got intensive outpatient, which is otherwise known as IOP. And oftentimes that is several hours of group therapy multiple times in the week. So usually it's 3 hours a day for 3 days a week. So they'll go Monday, Wednesday, Friday, 9 to 12, and they'll do groups the whole time. Okay. Partial hospitalization, that is where they will go and they would actually check into the hospital at 9 o'clock. They'll have a full day of activities and then they'll leave at 3. And they'll do all kinds of different things during that time. And they'll do that for 2 weeks. So they'll stay there during the day, but then in the evening they get to go home. Simple detox, which is just 3 to 7 days. That's usually what gets through most detoxes, right? Through medical care. Then there's residential detox, which is 28 days or more, depending on insurance and what patients are willing to access. And then also long-term residential, which is usually up to 1 year. These are your 6-month programs where somebody goes. Okay. Here's the ASAM. Again, we're going to go through all of these later. So I know there's whoa, it's a lot, but we'll go through all this. So the ASAM looks at 6 dimensions. Dimension 6 is behind my face. And then you just kind of assess a patient at each one of these and kind of go through which one you think is probably best. Okay. And actually, do we do that this slide? Yeah, here are the dimensions. Okay. Dimension 1, how likely are they to use again? So what is their acute intoxication or withdrawal potential? Number 2, what are some biomedical conditions or complications? Okay. Number 3, how is their mental health right now? Number 4, what is their readiness to change? Number 5, is relapse a common thing? So have they done this a lot? Do they have a history of chronic relapse? And then number 6, what is their living environment? So someone can decide, I want to go get clean, but mom and dad are still back at the house and they're using, right? They're like, somebody said, I'm ready for recovery. I'm done doing this. But they go back home and they're not ready. So that could actually be shooting yourself in the foot. So what you would do is you would assess the person at each one. And this is on the Canvas thing, so you'll be able to look at it. You're going to need this next week. And you kind of go through and say, all right, where is their readiness to change? All right, well, the willingness to explore. Okay, cool. Ready to change, ready for recovery. Has kind of sort of engagement treatment, not, I don't know, poor engagement treatment. Open to recovery, but needs a structure. Like you just kind of see like, where are they at? And then, okay, they're open to recovery, but they need a structure. Cool. So their level here is 3.1. Now we take each one of those, right? Because they're going to be different. And based on each one of those, we get to say, what do we think is the most appropriate? When we're determining level of care, we want to try to do the least restrictive possible to achieve the goal, right? So I would see, there was a time ago where like if a kid came in and they're struggling with marijuana, oh, send them to inpatient. They don't need inpatient treatment for marijuana use. That's hitting a fly with a sledgehammer. Like you don't need that, but the devil's lettuce. So we're trying to do the least restrictive treatment to accomplish the goal. Okay, cool. And then this is the matrix model, which is more for inpatient, that we're going to do all of these things together to try to get someone well. You'll see this more at residential or inpatient treatments. Okay, so they'll go in and they'll get a little bit of CBT and they'll get a little bit of contingency management, meaning they get rewarded for doing stuff. Like they'll get like a gift card or a little trinket or whatever for doing something. Family therapy, they come in and the family will talk to them. So those are all different levels. Okay, that's it. All right, on to week 6. We will do the first vignette next week. It's going to be a good time. Hope you have a good week. Hope you've had a good week, and I will see you next time. So, as always, Canadian geese are definitive proof that evil exists. Live mahalo. See you next time. Goodbye.